Good morning, everyone. Welcome to today's seminar. Thanks so much for joining us. My name is Courtney Byrd-Williams. I'm an assistant professor in health promotion and behavioral sciences at the UTHealth School of Public Health in Austin. I'm also a research faculty member in the Michael and Susan Dell Center for Healthy Living. So our webinar today is hosted by the Michael and Susan Dell Center for Healthy Living. The center's vision is healthy children in a healthy world. This webinar is also a research initiative for one of our center's projects, the Texas Research to Policy Collaboration. The Texas RPC project optimizes the use of Texas research, data, and resources to assist legislators in developing effective health policies. So before we get started, just wanted to make a couple brief housekeeping announcements. First, this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. Second, if you have any questions during the presentation, please enter them into the questions chat box. We'll have time at the end for a question and answer session. So today I'm excited to introduce our speakers from the Texas A&M School of Nursing, Dr. Robin Page and Alison Pittman. Dr. Page is associate professor at the Texas A&M University School of Nursing. She's an advanced practice registered nurse and certified nurse midwife. She's also a member of the Texas Maternal Mortality Morbidity Review Committee. Her research focus is maternal health disparities, and she is a member of our Texas RPC Research Network. Dr. Alison Pittman is a clinical assistant professor at Texas A&M School of Nursing, specializing in pediatric and adolescent health. Her research interests center on health promotion and well-being among children and families, particularly the underserved. She's committed to educating nurses toward eliminating disparities to improve the quality of life for children and families. So with that, again, welcome, and I hand it over to Drs. Page and Whitman.
Great, thank you. And good afternoon, everyone. And thank you to the Texas Research to Policy Collaboration project team and the Michael and Susan Dell Center for Healthy Living for inviting us to share this information today. Also, a special thanks to Caitlin Burns for her assistance with slide preparation. But most importantly, thank you to all of you, our audience members who are attending today to hear more about this important topic of maternal child health in Texas. Next. So, I'm going to be covering the maternal health topics, and for that portion, we'll be taking a closer look at maternal morbidity and mortality in Texas, including some terminology, language that's used to describe maternal mortality. We're going to look at some numbers, some data, Texas by the numbers. We're also going to hopefully increase your awareness about some resources that are available. We're going to look at access, maternal care access in Texas. We know we have many rural areas in Texas, so we'll take a closer look at that. And we're going to also look at some best practices and potential solutions to mitigate maternal health mortality disparities. So we'll look at some maternal care workforce and home visiting programs. Next.
After that, I will be covering the child health section, and we're going to focus on probably the most critical part of child health in our state, which is mental health. We're going to talk about the scope of the issue of the mental health crisis in our state, some of the contributing factors, and then we're going to move into resources. What does Texas have currently available for children who have mental health concerns, and what are some longer-term solutions that are in the works?
So this is data from the National Institute for Healthcare Management. This is actually adapted from an infographic that they put out looking at maternal mortality in the US. So when we're talking about maternal mortality, it's important that we understand what exactly we're talking about, because the terminology can be sometimes confusing. So when we use the term general maternal mortality, we're really talking about death that has occurred within the first 6 weeks after delivery. So you can see that term in the far right column on this slide, but we need to look closer at what do we really mean when we're talking about death surrounding pregnancy. So we use terms pregnancy associated mortality, which can occur up to 1 year postpartum, regardless of the cause. So these are deaths that may or may not have been directly related to physiologic effects of the pregnancy, but still occurred within 1 year of the person giving birth. Whereas pregnancy related mortality is actually death that was because of some complication or some physiologic effect of the pregnancy that directly contributed to the death. So these are standard definitions that the CDC uses, and these are shared across states. Because when we talk about maternal mortality data, we need to be sure that we're all on the same page and that we're all talking about the same thing. So next slide. So you can see most people think that pregnancy-related deaths actually occur at delivery. We typically think about this happening like in the delivery room. The truth is only about 17% of deaths occur at the time of delivery. You can see at 31% occur actually during the pregnancy, but the vast majority occur after delivery, up to that first year postpartum, 52%. So again, it's important that we're not just considering the postpartum phase during those first 6 weeks after delivery, but we need to follow women out for a full year after delivery. Next. So as Dr. Byrd-Williams mentioned in the introduction, I have the honor of serving as the certified nurse midwife representative on our statewide maternal morbidity and mortality committee. So you all may be aware of the report that was just released last December, so just a few months ago. That was the biennial report that is put together by Texas Health and Human Services. So this data is directly from that most recent report. And you can see here that maternal mortality rates in Texas and actually across the US are worsening. So 2013, our number was 18.9, 2017, 20.2, 2020, 23.8. Perhaps one of the most startling statistics of all of this is that 90% of these deaths were preventable. Now, you might be wondering, what do we mean exactly by preventable? Again, we have to be really clear with our terminology. So the committee determines that a death was preventable if they deem that there were feasible changes to either patient, provider, facility, system, or community factors that contributed to the death. And we are just beginning to look at deaths that occurred in 2020, which of course is when the worst of COVID started happening. And we know that COVID had a huge impact on pregnant women, with the biggest impact on COVID-related mortality being on Hispanic women. Next. So the report that was released in December by the committee was actually just a partial cohort, so that full data hasn't been fully analyzed yet. But based on those preliminary findings, we know that 44% of the pregnancy-associated deaths were pregnancy-related. So again, being really careful with our terminology about pregnancy-associated and pregnancy-related. But apart from looking at pregnancy-associated and pregnancy-related factors, the committee also considers contributing factors. And these are things like obesity, mental disorders, discrimination, substance use disorders, and violence, which would encompass suicide and homicide. And you could see the largest of the contributing factors is violence, suicide, and homicide. So these are leading causes of maternal mortality. Next. We also know that racial disparities are present in Texas, all over the US, not just in Texas, and that these disparities have persisted for years. This particular graph is from 2013, so this is 10 years ago, and you can see that non-Hispanic Black women have more than twice the ratio of maternal mortality than white women, and 4 times that of Hispanic women. Next. And these statistics are worsening. They're getting worse year by year. This graph is showing data from 2018 through 2021. And you can see that every year it's going up. It's getting worse. The disparities are worsening, but actually death, mortality amongst all races and ethnicities is worsening. Next. So some related issues to this, you might think, what is going on? Why are things getting worse? Well, I already mentioned COVID, but that really, we didn't really start to see that until 2020. But we know there are vast healthcare provider shortages. And this map of Texas, the dark counties are designated as health professional shortage areas for primary care. This is recent data for Texas. This is from the Rural Health Information Hub. And by the way, at the end, we have a comprehensive list of references. So if anyone wants to go back and dig deeper into some of this data, it's all there for you. But you can see Texas has major deficits in healthcare providers. We can break that down even further by looking at maternal care provider shortages, and then also mental health provider shortages, which Dr. Pittman later in the presentation will give us some more in-depth view of mental health provider shortages. But for now, let's take a closer look at maternal health care provider shortages. You can see that Texas is last in access to care. We rank 51 nationally in access and affordability to care. So Texas is dead last. And of all the counties across the entire country, the one with the highest proportion of women without insurance is a county right here in Texas, down on the border, and that is Hidalgo County. Next. So the March of Dimes in actually just last year, released a very interesting maternity care desert report. So this map, unlike the primary care provider map, is looking specifically at maternity care deserts. You can see to the right of the slide are definitions about what do we mean by a maternity care desert. So we have deserts, then we have some counties designated to have low access, some have moderate access, and a very few have full access. So in this map, it's actually the lighter counties that are the maternity care deserts. And you can see there are many in Texas. So basically in Texas, people who are pregnant or giving birth have nowhere to go. Over 22% of Texas counties have low or moderate, meaning not full access, and nearly half of Texas counties are meeting the criteria for maternity care deserts. 55% of Texas counties do not have a single OB provider, and you can see what that looks like in terms of numbers of women, real women, who live in a county without a single obstetric provider. Next. So I mentioned in the introduction that we were going to touch briefly on rural counties in Texas because we know that's a very significant proportion in our state. And we, taking a closer look at the data, know that we have a very high percentage of women not receiving prenatal care during the first trimester. This is also closely related to rural hospital closures, and often obstetric services are the first to get cut because they don't make as much money on obstetric services. So many women have to drive as far as 50 to 100 miles to receive care and to have their baby. And this is data from the Texas Collaborative for Healthy Mothers and Babies. So expansion of access to care is very much needed in rural areas. We already mentioned we have such a low proportion of mothers entering prenatal care in the first trimester, only 66% versus 76% nationally. And we have lots of babies being born in Texas. Texas has the 5th highest birth rate in the US. So needs in Texas, we have many rural counties. We also are one of the top states for substance use disorders, including arrest for heroin and fentanyl, and low rates of treatment in young and pregnant Texans. We have high rates of opioid prescriptions. We have gaps in mental health providers. We have a high need for substance use disorder providers, and intimate partner violence services are lacking in rural areas. Next. So what are some solutions and what are some ways that we can try to improve this sometimes dire situation? Well, one is to expand our workforce. And this could look like expanded training and educational for more providers, for more OB providers. This can be done through the use of certified nurse midwives. And just a quick description of how midwives differ. We often hear about, oh, we need more midwives and doulas. But I want to just describe that there are 2 different types of midwives that are in Texas. Certified nurse midwives who are advanced practice registered nurses, where a graduate degree is required and they can have hospital credentials. Certified professional midwives are not required to have a college degree, and so they're limited to out of hospital practice. However, they fill an important gap. And doulas, who are often lumped together with midwives, are actually non-clinical providers. They provide information and support to help women make decisions about birth, but they are not required to have a license or a certificate in Texas. Next. So just to share briefly a few of the initiatives that are happening, not only in Texas, but also across the US. The Alliance for Innovation on Maternal Health is an initiative from ACOG, the American College of Obstetricians and Gynecologists. They are basically, it's an initiative to improve the quality of services, to enhance the best practices to make birth safer, and with, of course, the ultimate goal to improve maternal health outcomes and save lives. They have what are called patient safety bundles, focusing on some of the leading causes of maternal death, such as hemorrhage, hypertension, cardiac, substance use, and mental health. Next. Safe Mothers in Texas is a program that the Center of Excellence in Forensic Nursing at Texas A&M School of Nursing is starting. This was a grant that is funded by the Office of Assistant Secretary on Health. Next. And this initiative is examining the association between intimate partner violence and substance use disorder during pregnancy. We know that intimate partner violence, for example, is that pregnant and postpartum women are at higher risk for this. And we know, again, that we have limited resources, limited providers. So this program at Texas A&M is leading a consortium of stakeholders from across the state to train providers on SUD treatment and IPV to address the intersection of what happens during pregnancy. This will include online and in-person education for providers and ultimately disseminate training bundles for this statewide pilot project. Next. So I'd also like to mention home visiting programs. There is a national program called Nurse Family Partnership that is present in approximately 23 counties in Texas. And it's a home visiting by registered nurses for first-time mothers, and they get paired with a registered nurse early during the pregnancy who follows them beginning early in pregnancy up until the child's second birthday. This particular program, this National Nurse Family Partnership Program, is really considered the gold standard for home visiting programs. You can see the counties in Texas where we have it, but you can also see the counties in Texas where we don't have it. So we need more expansion of programs like Nurse Family Partnership. Next. And so what are some best practices? Well, we need to extend coverage for postpartum women to 12 months. We know that during that fourth trimester, women are at risk for maternal mortality and morbidity. So we need to continue that care. It's also important for healthy babies. We know that healthy mothers raise healthy babies. We need to expand telehealth services. We found out during COVID that it works. We know that we can do it. And we know in these rural areas, these maternity care deserts, we know that we can perhaps reach women through telehealth. We talked about expanding the mental health workforce through midwives and doulas. We need to allow advanced practice nurses, such as certified nurse midwives, to practice to the full extent of their training and education. And finally, we need to increase the public awareness of warning signs. Next. So the Hear Her Texas campaign, Hear Her is actually a national campaign that really aims to increase public and provider awareness of warning signs during pregnancy and postpartum. So it's a wonderful initiative. And the next slide will be my final slide before we transition to Dr. Pittman's presentation. It's a 5-minute YouTube video of a young woman named Lila. She lives in Houston, Texas, and she is going to share her story with you about some complications she experienced during pregnancy and postpartum. Okay, so thank you all for hearing Lila's story. And that is the perfect segue to the second half of our presentation, where Dr. Pittman will focus on mental health concerns in children and adolescents. Okay.
Thank you so much, Dr. Page. And before I start, I just want to throw a little bit of sunshine towards Dr. Page's way. She was featured on the cover just this month of Texas A&M Foundation's Heritage Magazine, and just talking about her lifelong commitment to helping moms and babies, including in the Peace Corps, overseas. And so this is actually also available online. It's Texas A&M Heritage Magazine. The article is just so inspiring. I know there are a lot of nurses and other health providers that work with moms and babies, and it's just a great, inspiring read, and we're just so proud of her here at the Texas A&M School of Nursing. So we're going to transition a little bit to talking about adolescent and child health and the crisis that we're experiencing in Texas, which is really one of mental health. And we want to start with some information, some statistics. The CDC comes out with a youth risk behavior surveillance survey every couple of years. And a new update is about to come out from their February 2023 cohort. We know already from some preliminary reports that there are an increasing number of youth that are reporting depression, anxiety, even sexual violence in the years since the beginning of the COVID-19 pandemic. In the 2021 report, already 1 in 5 high school students had considered suicide. And there are also increasing reports from high school students on violence, feelings of hopelessness, and cyberbullying that all continue to be concerns. This is the report from the Texas RPC on child behavioral health that came out this year. We know that the rate of childhood mental challenges and suicidal ideation have been rising for years, and that has been exacerbated by the COVID-19 pandemic. The big takeaways from this report is that we have a severe shortage of providers, leaving many children untreated with mental health concerns. We have some funding, that American Rescue Plan funds that expire in December of this year. So we really need renewed funds for the Texas Child Mental Health Care Consortium and other programs that are really critical to help bridge the gaps in child behavioral health care. Next slide, please. We want to start with the most concerning evidence out there, which is the rates of teen suicide. In the YRBSS over the last 10 years, we're going the wrong direction. We have an increase in percentage of high school students who are experiencing feelings of persistent sadness and hopelessness, are seriously considered attempting suicide in the past, have made a suicide plan, or have attempted suicide. And Dr. John Ackerman, who is one of the leaders of the Center for Suicide Prevention and Research at Nationwide Health, came out and said, this is basically 9/11 happening every 18 months in this country. 3,000 children are lost and die from suicide. So that's the biggest concern that we have. In addition, here locally, the Texas Children's Hospital has reported an 800% increase in mental health visits from pre-pandemic levels to post-pandemic levels. Before the pandemic, their emergency rooms usually treated 50 to 100 children every month for suicide attempts, ideation, and self-harm. And now the average is 400 to 450 patients a month. Next slide, please. Let's talk about some of the contributing factors. What is associated with this increase in mental health concerns? These are the 7 contributing factors that have come out in literature and studies, and we're going to go over each of these briefly. The first one, next slide please, is the COVID-19 pandemic. The National Academies came out with a study report titled Addressing the Long-Term Effect of the COVID Pandemic on Children and Families. And what we found is that children were experiencing illness and death in their loved ones. School closures, the lockdown contributed to social isolation, which led to increased anxiety and depression. There's also financial hardships increased, food insecurity, and deleterious mental health effects, including limited access to care. Unfortunately, low socioeconomic groups and also Black, Latino, and Native American groups are disproportionately bearing the brunt of these negative effects of the pandemic. The recommendations that they made were to prioritize these mitigating effects, especially in these disparate groups, to help children process, cope, and rebuild, which means we need more mental health providers. And also pandemic proofing, establishing a mental health plan in our society for another potential lockdown where we have social anxiety. Next slide, please. Another contributing factor is social media. For better or worse, social media is not going our way, and our youth, our young adults love it. It has great benefits, as you can see here, but some of the risks that have come out in the literature from excessive use of social media and being on their phones too much is, of course, sleep deprivation, decrease in school performance, mental distress, increased self-harm and suicidality, an increased risk for obesity, and of course the exposure that they may have to risky content such as cyberbullying and solicitation. For solutions on this, the American Academy of Pediatrics has established a Center of Excellence on Social Media and Youth Mental Health, and some of their recommendations include setting limits with your young adult, including having a media plan agreement that you sign with the two of you. Also co-viewing social media with your children, talking about internet safety and facilitating their health and development, for example, encouraging physical activity. Next slide, please. When we look at stigma as a contributing factor, remember, stigma is just the negative attitudes and beliefs that we have, and in this case, about mental health. And there's really three main categories. There's structural, also known as institutional stigma, where we really don't offer mental health services or opportunities for people to seek help. There's also societal stigma, also known as public stigma, where within society we trivialize mental health concerns. We blame the victim, the person who is experiencing the illness, and we also are known to label those with mental health concerns as less than or incompetent. And then, of course, there is self-stigma, where the individual exhibits self-blame and feelings of low worth and failure. So definitely a contributing factor to this epidemic. In the next slide, you see an infographic from Children's Health Dallas that examines some ways for us to just end mental health stigma. And these include educating yourself and your children about mental health, sharing real life examples and stories of those with mental health disorders and their overcoming of those disorders, and then explaining that mental health has a wide range of symptoms and severities, and of course, listening to and supporting others with mental health concerns. So getting it out there and talking about it is a really important way to end the mental health stigma. The next contributing factor is really a severe one, and that is the lack of providers and resources. This kind of mirrors Dr. Page's "know where to go" slide. And a quote from Herschel Lesson, who's a physician in New York: "They want us to screen for depression. They want us to screen for anxiety. You get a positive, what do? There's no resources, nowhere for me to refer children for mental health in my community." This mirrors another article in Medscape from pediatricians that just outlined that they can't be the only providers, to bear the burden of teen mental health in our country. Next slide, please. There's also the financial burden. There's very low mental health treatment reimbursement from both Medicaid and private insurance. And what this has led to is many mental health providers in Texas only accept cash. Only 55% of psychiatrists, as an example, accept private insurance, and only 21% will accept Medicaid, and that's according to the Texas Medical Association. So the patient has the burden on themselves to bill their insurance or to bill Medicaid, which is very difficult for many people. In addition, only 12% of children in Texas I'm sorry, 12% of children in Texas don't have any coverage. They don't have Medicaid or CHIP or private insurance, and that is the worst in the country. That's double the national average. Next slide, please. Another interesting factor that a lot of people don't realize is increasing school pressure. There's been a lot in our sort of mass media, including a Frontline episode on PBS, about the increasing pressure of school on our high school students. College applications are increasing, and there was a really big rebound following the COVID-19 lockdown, but unfortunately, record low acceptance rates. We have, especially in Ivy League colleges, acceptance rates decreasing. In addition, the removal of the SAT and ACT as an admission criteria means that grades are even more important. And this is particularly true in what we call high achieving schools, college preparatory schools, in which there's what a lot of media call a grind culture, where students are very pressured to achieve well in school following the COVID-19 pandemic. Next slide, please. And lastly, when adults around a child or adolescent have poor mental health, there is, of course, negative effects on the child. And we are seeing a lot of reports that U.S. parents' mental health quality decreased during the COVID-19 pandemic. Next slide, please. So let's talk about the resources that are available right now in Texas for mental health. One issue is providers. There are over half of Texas independent school districts, 593 to be exact, that have no psychologist or a licensed mental social worker on staff, and that's according to an analysis by CBS News from the Texas Education Agency. And if you talk to people in your life who are trying to seek mental health for their child, you can hear it firsthand that it's very difficult to find a psychologist, a licensed professional counselor, or a social worker that is taking new patients. They're all completely overbooked and have waiting lists for new patients. In terms of facilities, there are 9 state hospitals and 1 state residential youth center in Waco. In March of this year, the Texas Tribune reported that despite Texas adding millions of dollars into upgrades for their state hospitals, they can't stay staffed. There's reduced capacity, massively increased demand, and lack of staff. Salaries are being increased for the vacant positions. Over 20% of positions at the state hospitals are vacant. And the HHS has estimated the average wait time for forensic admissions is 323 days. In Dallas County, it's 831 days. Most admissions to state hospitals are from incarceration, even in youth. So people are waiting up to 2 years for a bed in a state hospital to get mental health treatment. There's currently a bill in the Texas House 3396 that calls for HHS to ensure that each state-funded forensic bed is open and usable no later than August of next year. We also, of course, have children's medical centers who have behavioral units, and there are also private psychiatric hospitals and crisis stabilization units, but not all of these allow children. Next slide, please. So here's our equivalent of the maternity care desert. Here is the psychiatric care desert. All of the counties that are shaded in gray have no psychiatrist or psychiatric mental health nurse practitioner. And of these 164 counties, 137 are rural. So that's where the deserts are. In terms of mental health nurse practitioners, they fill a gap in provider shortage. There are over 1,400 psychiatric mental health nurse practitioners in Texas. And if we reduce the scope of practice restrictions currently in place on NPs in Texas, that would reduce the psych provider shortage by 13%. There's also the option of physician assistants. Unfortunately, only 1% of PAs work in psych and psychiatry. This is really attributed to a lack of understanding on how to use PAs in psychiatry, inconsistencies in training, and lack of track options in psychiatry. Next slide, please. There has been an increase in the number of counties that are designated as mental health professional shortage areas, from 80% in 2016 to 96% in 2023. And that's defined as more than 30,000 residents per clinician in that county. Texas ranks last amongst 51 states in terms of access to care for mental health. This really mirrors what Dr. Page mentioned, the Commonwealth Fund report. This is a report from Mental Health America, which is a nonprofit advocacy group. And ranking last is based on criteria such as the number of youth who have a mental health diagnosis who don't have access to services, those who have a severe diagnosis who did not receive consistent treatment, children with private insurance that doesn't cover mental health or emotional problems, and children identified with an emotional disturbance who have an IEP and limited workforce availability. Next slide, please. This is just a snippet of a social media post from the Washington Post. They had an article about Zach Chafos, and he was in Maryland, but it could just as easily happen here in Texas, where he has autism. He needed mental health crisis therapy, and he waited 76 days in a Maryland ER waiting for a bed in a psychiatric facility. This was in November of 2020. Unfortunately, he passed away unexpectedly in August of 2021, but this story just really highlights the issues that we have with getting mental health inpatient crisis treatment in our country. Next slide. In terms of solutions, the first one we need is more inpatient beds. And as mentioned before, there's the House Bill 3396. And we also have the options of non-state-owned inpatient units. Secondly, we need more outpatient crisis treatment centers. So crisis stabilization units are designed to treat mental illness for those who are at high risk of admission for up to 14 days in a crisis situation. And the U.S. Department of Justice just recently awarded $21 million to Texas for additional mental health services, crisis treatment, school mental health services, and telehealth. This was called the Bipartisan Safer Communities Act, and it was really a response to the Uvalde shooting in February 2023. More outpatient therapy. Daryl Spinks, who is the ED of the Texas Behavioral Health Executive Council, says we don't have enough people coming through the door to meet those who are coming out. So current efforts for more outpatient therapy, psychiatrists, counselors, are student loan repayment programs for mental health providers and incentives for ISD to hire social workers and mental health professionals. And that leads to our last bullet point, which is more mental health support in schools. Next slide. A few more solutions to close out. We have a lot of burnout in our mental health providers. In this quote from Daryl Spinks, he says the job itself is demanding. Nobody comes into your office having a good day. And so the burnout can be significant, just like we're seeing in a lot of other providers, especially post-pandemic. So providing some resources to prevent burnout in mental health providers would be important for those in our state. And then, of course, improving reimbursement. Evidence suggests that low reimbursement is a significant financial disincentive for mental health professionals to treat Medicaid enrollees and certain private insurance programs. I want to end by talking about resilience. Resilience, as we know, is successfully adapting to difficult and challenging life experiences. And there's a lot out there in terms of factors that contribute to childhood resilience in the face of stress and potential mental health concerns. And so there's so many factors that contribute, but there are three that really stand out. And those are cognitive development and problem-solving skills in our teens and children, the concept of self-regulation in the face of stress in terms of emotions. And then lastly, does the teen have a relationship or multiple relationships with caring adults? And there's more and more evidence that while some of us have more intrinsic resilience than others, resilience can be learned and taught and cultivated in our young people. Next slide, please. So lastly, these are some of the bills that we wanted you to be aware of if you're a bill tracker like us in terms of bills that are currently in Congress in Texas. We talked about HB 3396, which is still in committee. House Bills 1898 and Senate Bill 1365 are designed to increase children's hospital capacity and their ability to care for children with mental health concerns. There's also two House bills that are contributing to loan reimbursement, student loans for mental health professionals. These are all still in committee. And then Senate Bill 1700, known as the HEAL Texans Act, gives full practice authority for psychiatric and mental health nurse practitioners, and that is still in committee. And then lastly, the last three bills increase Medicaid coverage from 60 days to 12 months for postpartum women. And House Bill 12 is actually out of committee and on the calendar. House Bill 56 and Senate Bill 72 are still in committee. So if you want to track these bills, you can see what our lawmakers are doing locally to try to improve maternal child mental health. This concludes our presentation. We hope it's given you a good overview of our current state of mental child health in our great state of Texas.
Great, thank you so much, Drs. Page and Pittman. We have so many questions rolling in. Again, for those of you in the audience, please, if you do have additional questions, enter them into the chat box. So I'll just start off. One participant asked, this is so sad. Many of the deaths that are up to 1 year postpartum, most of the deaths are up to 1 year postpartum, yet Medicaid provides health coverage to low-income pregnant women during pregnancy and 2 months after the birth of the baby. Are there beginning to be any changes in policy? And I think you spoke to that a little bit, Dr. Pittman. Did you want to say anything more about that bill? You said it's still in committee.
I'm sure Dr. Page also has probably a better impression, but it's just important for us as citizens of the state to kind of track these bills and see where they go. The good news is there were 3 different ones, so there were several lawmakers that really made this a priority. I think it's just a matter of which one makes it on the calendar and gets approved first.
Yeah, and I would just add to that. So I do believe that the last session extended care for 6 months postpartum in Texas. However, I think it got hung up somewhere along the way between being passed and then being implemented. So that's still out there, but I think the question was asking, have we made any progress? So I would say yes, I definitely consider that as progress. And I think more and more people are just aware of the need to have coverage until that 12-month postpartum period. I mean, you know, we covered the children. I mean, just like the questioner asked, we covered the children after birth, they get care, but I go back to healthy mothers raise healthy children. So we have to continue. So many women fall through the gaps after that 60-day postpartum mark when they lose their Medicaid coverage. So yeah, so, but I agree with the questioner, it is sad.
It is sad. There are a couple questions related to virtual appointments. So one question is, how has virtual appointments helped increase access to care?
I can speak to that some. In Texas, we have the TCHAT program, TCHATT, which Texas A&M is a partner of. And that was kind of an emergency measure during the COVID pandemic, but it's been extended where within school districts can partner with the TCHAT program, and they provide, I think it's up to 5 to 10 telehealth visits that a child can have at school with a mental health provider when there's not one in the area. So when you think about our rural school districts, if they have an internet connection, a child can take a break from class, come sit in the counselor's office in a private area, and have at least some initial assessment and referral visits with a mental health provider that can connect them with someone more long-term if they need it. It's not really a crisis, you know, it can be sort of if it's a mild crisis, that can be one intervention, but we're really looking at a lot of these bills in Congress that are going to extend the funding for that TCHAT program and other programs like that in the state.
And I would say for maternal services, we saw during COVID when a lot of offices were closed to, you know, having patients come in unless they were critical, that we were doing a lot of prenatal visits through telehealth. And, you know, we can give women blood pressure cuffs to check their blood pressure at home. We can give them scales to check their weight. Those are two of the key things that get checked at every prenatal visit. They can do that at home through a telehealth and then share their findings through the provider on telehealth, and then go through that list of questions and concerns. And so I think really COVID helped us a lot in that regard, to show that actually we could do it. And maybe it's a way to rethink that access to care issue.
So that makes me kind of sad to ask the next question that came in. There is a new bill proposed to eliminate payment of telemedicine services. With the staffing shortage, how can we provide services without utilizing telemedicine?
Well, I think a lot of that goes to expanding the healthcare workforce. And, you know, we've talked a lot. Of course, we are both nurses, both Dr. Pittman and I are nurses. And, you know, just thinking about advanced practice registered nurses, whether it's something like a certified nurse midwife or a family nurse practitioner, a women's health nurse practitioner, a psychiatric mental health nurse practitioner. But this is a way that we can expand the workforce. And we know that in states that have allowed full practice authority, the access and the outcomes are better. We have that data to support this. So we can see by all the metrics, Texas is doing poorly in the areas of access to care. So we have to think outside of the box to how can we expand access and allow Texas citizens to be cared for.
Yeah, I would echo Dr. Page and say that psychiatric and mental health nurse practitioners really, you know, when you looked at that map that I put up from the Texas Nurse Practitioner Foundation, they really fill the gap, especially in rural areas. If we have someone in that role in a rural county that does not have a psychiatrist, they can travel around and provide face-to-face services, especially if the funding for telehealth goes away. And I would really like to hear more about the rationale. I don't know as much about that bill, but I'm wondering if it was because it was a temporary measure during the COVID-19 pandemic. If so, aside from the pandemic, the massive gap that it has filled in rural areas, whether we're in a pandemic or not, really needs to be looked at.
And I would also just add, besides healthcare providers, we can help fill gaps through things like community health workers who live in communities and can be trained to do basic screenings and provide education and can be patient navigators. So, and doulas, who I mentioned during my presentation, particularly trained to support, educate, and inform pregnant women. So there are also alternatives to direct healthcare providers that can help fill some of the gaps.
Great, these questions are just rolling so nicely. So the next question is, have there been increases in funding for scholarships to recruit new midwives? And based on your responses to the last question, I'll add CHWs or doulas in Texas specifically.
Gosh, I wish I could say yes. I'm not aware of any such programs. It doesn't mean that they're not out there, but I'm certainly not aware of them. But I think it's a great idea. Certainly there have been similar bills, though, to support nurses, because we all know there's a nursing shortage nationwide and in Texas as well. And there is legislation to support training more or educating more nurses, and then also nursing faculty. We know there's a big shortage of nurse faculty, and if you don't have enough nurse faculty, you can't educate more nurses. So, you know, I certainly see opportunity there. We've done it to support the broader nursing education. So certainly I think it could be done to support like more OB providers, like nurse midwives, and family nurse practitioners also sometimes serve in OB settings and can certainly be primary care providers and OB care providers. So yeah, so it's a great idea, and there's definitely opportunity there.
There is the Nurse Corps program, and any certified nurse midwife or you know, nurse practitioner that works with moms and babies is also a registered nurse. And the Nurse Corps program provides loan reimbursement for nurses who work in underserved areas, and this definitely qualifies for that. So that would be one that's been in existence for a long time, but that would be one loan reimbursement opportunity for nurses that work in this area.
Great, thank you. The next question says, thank you so much. How can we contribute? Do these initiatives hire and/or need volunteers?
Ooh.
Hmm.
Well, I would say depending on your you know, your area of healthcare, you know, really looking into opportunities. If you know, there are specialty tracks for psych and for maternal child health in many different programs. You know, we are starting a psych mental health nurse practitioner program here at Texas A&M, and there are lots of others across the state. Advancing your education as a provider is a great start, and then, you know, finding a place where you can advocate for your community is always a good step. Dr. Page, do you have anything to add?
Yeah, I guess how you could help if you're not a nurse, go to nursing school. We need more nurses. We happen to know of a great program, but honestly, there are many great programs throughout the state. But I think there's a lot of great initiatives. I highlighted just a few of them. Texas Research to Policy Collaborative is one of them, who I think is doing great work. I can't speak quite as specifically to the Michael and Susan Dell Center for Healthy Living, but I think certainly they do great work and have great initiatives going on. So, I think just kind of getting out there on the internet and seeing what's available locally too in your community, because we know so many communities are untouched and have such a need. So I think just trying to find out what's available locally and raise awareness of resources that are available, because that's another thing. A lot of people aren't aware of what the resources are.
Awesome.
Can I just add one more thing that I'm sure there are a lot of parents or about to be parents in the audience, and just seeing what's in your local school district in terms of resources for moms and babies and for mental health is really an important thing to look into and to advocate for with your local school district.
Awesome. Well, thank you both so much for such an amazing presentation. Thank you everyone for attending today. We really appreciate you guys being here. Remember, this webinar will be archived on our website at msdcenter.org. And again, thanks again for joining us today. We'll see you for our next webinar.
Thank you.